Tony, thank you for the introduction, ladies and gentlemen. Electroimpedance tomography, clinical reality, and vision. Well, when you look in the past, there was the belief that ARDS is a diffuse disease, and in the 80s we learned more about it, that we learned that we have densities localized in the dependent lung areas that are not ventilated, not well ventilated, but very well perfused, contributing to interpulmonary shunting and the severe hypoxemia. And when you want to see such images, it was necessary that you wanted to look at regional ventilation. You needed to have a CT scan. Well, that is not applied at the bedside, you know that. There's radiation, and of course you cannot use CT for continuously adjusting mechanical ventilation. When you want to do that, an option would be to give a belt, an electrode belt around the chest wall, and to create electroimpedance tomograms, displaying you the ventilation from end expiration to end inspiration, and you see that the ventilation takes part, in this case, in the anterior part of the lungs. And I think that is a very important technology that is available at the bedside, that is a non-invasive monitoring device and is continuously applicable. Well, the principle of operation is that you inject the current and you measure the potentials with the electrodes in pairs. You use all 16 electrodes, and then you get an electroimpedance tomogram. And the preparation time is quite not very long. It's about 4 minutes. You lift the patient once, and you use an electrode belt, because then you can guarantee the electrode plane, and that is normally placed in the 4th to 6th intercostal space. There is an image reconstruction. You can use different image reconstruction algorithm. For instance, the back projection, similar to that what you have in the CT scanning, to localize certain processes within the lungs. But what does the image tell you? The image displays differences of impedance with respect to the end expiratory reference level, and then it's color-coded. So the old system was from the typical rainbow colors. You will see that also in my presentation still. But the new one is to have a monochrom scaling from dark blue to white. And you see from the reference level an increase in impedance, and that is related to an increase in ventilation. And it's very important that you notice that the image displays ventilation, not the lung itself, so it's not a technique that can be used to look for morphological changes. You have to use for that, for instance, the CT. So when you look at the ventilatory cycle of spontaneous breathing, expiration, inspiration, you see an increase in ventilation, a decrease. And at the bedside, it will look like that. It's a dynamic image, and you can see how this healthy volunteer is breathing. You can, of course, also look at a static image, and you use a cursor to look not only on the global impedance change, the global change in ventilation, but you can look at the local ventilation at the cursor position. And I think that is a very unique option this technique gives you. There have been validation studies using the device. You see the gas content in the CT scan, change in impedance with the electroimpedance tomography, and you see a good correlation in all quadrants of the lungs. And also when you ask for the Bland-Altman plot, you see acceptable results. So obviously this technique is able to look at regional ventilation. What information do you get? You see, for instance, electroimpedic tomogram like that. You see that obviously in the left lower lobe there is a decrease in the impedance change, and that was due to a ruptured diaphragm in this case. You can also look at such an electroimpedance tomogram where you see almost no impedance change, almost no ventilation on the right side before and after doing a recruitment maneuver, showing you a more even distribution of ventilation. And you can also look on the tidal change of the global or a regional impedance curve. Here you see a recruitment maneuver, and then you can look also on the changes of the end expiratory change in the impedance curve. Again, looking at a recruitment maneuver, now looking at slices, and you can see the change in the ventilation in the different slices. You can use also cursor positions to look at the specific lung region during such a recruitment maneuver. So when you look on the new device, you see two electro impedance tomograms before and after a maneuver, and you can also look at the difference between the two images, telling you if you have an increase or a decrease in ventilation and in what areas. In this case, you see, indicated by the orange color, a de-recruitment phenomenon. Oops. Next one, again, two maneuvers. The difference image now indicating light blue color, an increase. So obviously you see in the whole lung an improvement in the ventilation. Data from our group, you see a recruitment maneuver with a low gas flow, the global impedance curve, the regional impedance curves, and when you look very careful, you see that obviously de-recruitment occurs at different times. Recruitment of the most dorsal quadrants occur with a delay, and this delay is obviously related to the fractions of recruited atelectasis you see after the recruitment maneuver in a CT scan. So it has something to do with the distribution of ventilation and the potential for recruitment. And Hermann Wigge will show you in detail data on that. You see here that you can also look on the change of the location of the magnitude of the ventilation with respect to a change in beep. But you can also look at changes in this delay, constructing delay maps. And you see that with different peep positions you see differences in this delay, differences in the homogeneity of mechanical ventilation or ventilation distribution. I only show you that, and it's discussed then in detail, because I try to give you not only what we can do now, but what will be the future of such a system. And I think that is probably the vision, and that has also something to do with improving ventilation care. So we have this functional EIT. We already can do such delay maps by doing a different reconstruction of the data of the electroimpedance tomogram. And I think it's important to mention that it is a non-invasive method. It's applicable at the bedside. It measures regional ventilation changes over time after maneuvers, and you will also see some data how you can adjust mechanical ventilation, for instance, PEEP. But the real future, I think, is that we would like to see such images. That was done in 1994 Balam and co-workers measuring with a SPECT in supine and prone position VAQ, regional VAQ. And you see the animal was placed from supine to prone. White is indicating dead space, purple shunt units, and a more even distribution of VAQ matching. I have shown you data on the electroimpedance tomography measuring ventilation, that are data showing you perfusion measurements with the EIT. That has to be developed, that is not ready on a commercial available unit at the moment. And the goal is for sure to have a EIT measurement of the ventilation perfusion. And that, I think, would be the real revolution to adjust mechanical ventilation in the critical ill.